So in terms of infertility from cancer treatment, about a quarter of cancers are diagnosed when women are still fertile. So that'll be up to age early 40s. And for young women diagnosed with cancer, loss of fertility is a major concern. And infertility, there are a number of different cancer treatments that can cause infertility, such as chemotherapy, certain chemotherapies, radiation treatment that affects the ovaries, or surgery where the ovaries are removed. But for women who've had chemotherapy, whose periods stop after their treatment, it can be very difficult to know whether or not they have permanent infertility. So sometimes the ovaries stop functioning after cancer treatment, particularly chemotherapy, and then they can start functioning again at a later date. And we don't have any good ways of predicting that at the moment. Radiation to the ovaries, such as the kind of treatment that might be offered for some kinds of cervical cancer, will almost always lead to infertility. And even if periods return after cancer treatment, fertility may still be reduced compared to another woman of a similar age. So in terms of what can be done for infertility after cancer, an injection of a medication, hormonal medication, called Zoladex, before chemotherapy starts is helpful for some younger women having treatment for breast cancer. It hasn't been shown to work for treatment for any other cancers. The other options for women who want the option of getting pregnant in the future, and there's an opportunity to delay the start of their cancer treatment, collecting eggs or collecting embryos, which are then frozen, might increase the chances of future pregnancy. But this will require a delay in cancer treatment. And as I said, sometimes that's safe to do it and sometimes it's not safe. The other thing that can be done, which doesn't require a delay, is collecting ovarian tissue, which requires surgery, and that can be frozen and potentially reimplanted. But around the world, so far, there's been few pregnancies from that technique. So for younger women who are facing cancer treatment that may cause infertility, they need to make decisions very quickly and often under pressure and often with a lot of other information going on at the same time. And there's recognizing that there have been a few groups, one our group in Melbourne, and this Cancer Fertility and Me site that I just found looking on the internet, which is from the UK. These are ways of supporting women to make those choices. So weighing up not only the information about the pros and cons of different approaches, but also their own particular values and their own requirements and thoughts about having children in the future. And using one of these decision aids, which is what they're called, actually make patients feel more comfortable about their decisions, able to make quicker decisions and less likely to regret their decisions in the future. So infertility and menopause are closely related. Infertility is when the number of eggs within the ovary is depleted, and menopause is when the eggs within the ovary is depleted to a very low number, such that ovulation doesn't occur anymore. And cancer treatments that cause infertility often also cause menopause. So menopause, of course, is normal and affects all women at around about age 50. And it's called premature if women are under 40, and it's called early if women are under 45. And chemotherapy, same kinds of chemotherapy I was referring to earlier on, radiation or surgery to remove the ovaries, can also cause menopause, and that will be premature or early depending on the age of the woman at the time. As well as that, what's called endocrine therapy, which are estrogen blocking treatments that are given after many breast cancers, can cause menopausal symptoms, and those sorts of treatments include drugs like tamoxifen or aromatase inhibitors. And menopause can affects women very differently, but some of the common symptoms that are reported include hot flushes and night sweats that can disturb sleep, vaginal dryness, which might lead to pain during sexual activity, sleep disturbance and mood disturbance. And it appears that those kinds of symptoms after cancer might be worse than they are compared to women experiencing natural menopause. So how can you treat those symptoms? Well, HRT, or hormone replacement therapy, is an effective treatment for menopausal symptoms, particularly hot flushes and night sweats. And it should be avoided after breast cancer, but it's usually safe to use after most other sorts of cancer. So it's certainly, there's no one-size-fits-all about HRT after cancer. As well as that's a drug treatment, obviously a prescription therapy, but there are drug-free treatments that are also effective. So cognitive behavior therapy, it reduces the bother or troublesomeness of vasomotor symptoms, hot flushes and night sweats, and it may also improve mood and sleep. And clinical hypnosis is also effective. And in addition, there are now medical therapies which don't contain hormones, which are effective for hot flushes. And some of these are antidepressants, and other drugs include a medication called gabapentin, and there are an increasing number of these medications. So I guess the message from this is that you don't need to necessarily avoid HRT if you've got troublesome menopausal symptoms, because either you don't need to just put up with troublesome menopausal symptoms, because either HRT might be a good idea, or if not, there are other treatments. So just to sort of summarize that, I've just put together a little table for around HRT, when it should be avoided, which is after breast cancer, and the other cancers where it can be considered. And you can see for most cancers it's something that can be considered. And there, as I mentioned, there are a number of effective non-hormonal treatments. So the antidepressants I mentioned before, gabapentin, a drug called oxybutynin, which is also used for overactive bladder, and a drug called clonidine. So quite a few options. And in terms of what's new, because this is a very active area of research, I think as clinicians, we understand that many women are really struggling with menopausal symptoms after cancer, and there just aren't enough therapies available. So I've just put up here two articles that have been published recently. One is fezolinetant, so that's a brand new targeted non-hormonal therapy for hot flushes, which appears to be very effective. It's going to be approved in the US, I think early next year, and I think there'll be applications to have access to it in other countries. And the second one is a paper from the Lancet this week, which I was involved with, a study of Q122, which is another non-hormonal treatment. And this study we did in women who had breast cancer who were taking tamoxifen or aromatase inhibitors, and it was also effective. And the drug-free treatments I've mentioned before about CBT, hypnosis, acupuncture, we don't really know enough about. We're getting different results from different trials for hot flushes, but a recent study published in JAMA last week showed that acupuncture for pain due to aromatase inhibitors, so for joint pain, the acupuncture seemed to be effective. So I think that's an exciting development, because there hasn't been much in that field. And in terms of information resources for women, this is one that we have done in Australia. There may be, the others can tell me, a guide, similar guide for Ireland, but this is also accessible for anybody who wants to look at it. So I'm going to move on to sexual difficulties after cancer. And I think it's kind of reasonable to say that almost everyone experiences some impact of cancer and its treatment on their sex lives. For women, multiple reasons that might include, but not limited to, vaginal dryness, the effect of cancer and its treatment on body image and relationships, on mood, with anxiety and depression, and also grief and anger. So many different things, often difficult to divide up one thing from another. And almost everyone finds it difficult to talk about sex, including the clinicians. So vaginal dryness is one of the easier ones of those to address. And I think Yvonne will talk about other kinds of approaches to other common symptoms. Vaginal estrogen is more effective even than taking HRT for vaginal dryness. And it can also prevent recurrent urinary tract infections, which is a problem that some women experience after menopause. Whether or not vaginal estrogen can safely be used after breast cancer, hormone-sensitive breast cancer, is something that's still in discussion. Nobody's really sure, but as far as we know, the information suggests that it's safe. But it is an individualised discussion, really, with your clinician about that. In terms of non-hormonal treatment for vaginal dryness, moisturisers, again, Yvonne might comment on these, but it's not many studies really that have shown that they're effective. Lubricants, we did a randomised trial on silicone-based versus water-based lubricants in women who'd had breast cancer. And we found that the silicone-based ones were a bit more effective, but something like 86% of women still had pain despite using lubricants. So we came away from that not feeling very confident about lubricant use. And there is one study on local anaesthetic to the vulva to reduce pain with sex. So I'm just going to talk about sleep and then about mood, and then I think we're going to take questions at the end. Is that the plan? Yeah. So sleep difficulties after cancer, again, a really common problem. So women are more likely to have sleep problems than men across our life course. Those things can increase over the menopause and also with cancer treatment. So a number of different reasons why sleep can be affected. And sleep problems can start off as being intermittent but then become persistent. And of course, if we don't sleep properly, it affects our mood and affects our daytime function. And importantly, can also increase the risk of developing depression. So in the UK, the NICE guidelines have recently recommended the use of online CBT for insomnia. Fionán, are you going to talk about that? Yeah. And so I won't go into that because he knows much more about that than I do. And I think he'll mainly be talking about this particular program. So I'll talk now about mood. And depression and anxiety are more than twice as common in women compared to men across the life course. And for women transitioning menopause or experiencing a diagnosis of cancer, those who've had previous depression or anxiety are more at risk of it happening again. Women who are socially isolated, who abuse alcohol, experience any kind of other sexual abuse or violence, and those who have financial hardship are an at-risk group. And the end of treatment is end of cancer treatment is a particularly risky period. And I think many of you probably will recognise that, but it's something that sometimes the treatment systems aren't, once you're treated, aren't necessarily going to be so available for you at that point. So in terms of managing mood disturbances after cancer, then getting information, being aware who's at risk, being aware that you may be at risk because of your circumstances, your history at the time of your diagnosis, talking with your support team, financial help. Often this is a very stressful, people talk about financial toxicity in cancer, and I think recognising that what a big deal that is for many women particularly. Looking after your body and exercising if you can, finding ways to deal with anxiety such as mindfulness or meditation, and getting treatment. So these are all difficult things to do if you're experiencing anxiety or depression, but potentially something that can help in the circumstances. So in summary, the kind of common symptoms I've talked about after cancer include infertility, early menopause or menopausal symptoms, having disturbances in your sleep, difficulties with sex, and disturbances of mood, for example, depression or anxiety. Many of these are temporary, and they all can be treated. So it's important to ask for help. Thank you.
Okay, so welcome everybody. I'm only doing what I'm told. Better? If I come away from the thing over there. Okay, so we've people joining tonight online. I want to welcome all of them as well. And we even have somebody joining us from South Africa. So welcome to everybody. I have apologies tonight from Professor Donald Brennan. The weather caught him as well. So it's we'll miss him, but that's the way it goes. I'm now going to call on Dr. Fionán to come up and introduce himself.
Hello, thank you very much. My name's Fionán Donohoe. I am a gynecologist, and I suppose what qualifies me to be here as the only man in the room other than Seamus is I spent the last 2 years doing a research project under the supervision of Professor Brennan for women who have menopause symptoms, hot flushes, sweats, and those types of symptoms, sleep disturbance, who had a history of cancer and who couldn't use HRT. So what I'm going to talk about, some of it will be a little bit of overlap with what Martha was speaking about. We'll just give an overview about cancer and menopause, some of the common symptoms and some resources and information, I suppose, psychoeducation around the different interactions between cancer and menopause. So I'll open up my presentation. Load. Here we go. Great. So that's me. So when we use the term menopause, what are we talking about? And if we're being strict about it, the term menopause means the last menstrual period that a woman has in her life. But in more modern language, it's come to represent the syndrome, the different symptoms and signs associated with that final menstrual period and the lead up to it. So perimenopause is a very common term that we hear talked about, and especially we're having this national and international conversation about menopause and menopause symptoms, thanks to Joe Duffy and Davina McCall and lots of other people. But perimenopause is a word you hear bandied around a lot, and it means the time from the onset of menopausal symptoms until menstruation stops. But this can be a very confusing time if you're experiencing menopause, or a very confusing term rather, if you're experiencing menopause symptoms. When your symptoms have been induced by cancer and its treatment, it often doesn't fit well with the experience. And then postmenopause then is when there's been no vaginal bleeding for 12 months or more. So the menstrual cycle is regulated from two glands in our brain, the hypothalamus, the pituitary, which sends signals to the ovaries to create estrogen, progesterone, and testosterone and other hormones which are involved in the regulation of the menstrual cycle. And you can see on the left side of the screen here the different hormonal changes over the course of the menstrual cycle. But what happens as we age, or if we undergo certain types of cancer treatment, is that the estrogen is no longer produced, the levels fall, and menopause symptoms follow. So where does cancer come into it? And I'm going to take a little bit of time to kind of explain how cancer and menopause interact. So surgical menopause is when happens when the ovaries are removed at surgery in someone who is premenopausal. So this means that the ovaries are removed and estrogen therefore is no longer produced. And we see this most commonly in gynecological cancers like ovarian or womb cancer, but sometimes also in bowel cancer. If it is spread to the ovaries, surgery might require removal of those, or in women who have cancer predisposition syndromes like BRCA or Lynch syndrome or other genetic alterations, whereby removal of their ovaries is a preventative measure. And then that can also be important in the setting of breast cancer, where the ovaries may be surgically removed as a form of ovarian suppression to prevent the risk of recurrence. So with surgical menopause, it can be very accurately timed, so you know exactly when it happens, and it's permanent and irreversible. Looking then at pelvic radiotherapy, so we know radiotherapy very effectively kills cancer cells, but if it's given in the pelvis, obviously the ovaries get the same dose of radiation as whatever cancer is being treated, and which causes them to lose their function. And we see this most commonly in cervical cancer in terms of gynecological cancers, but also in rectal cancer. And we know this is on the rise in premenopausal women and women under the age of 50. So it is becoming more relevant now. We're going to see more younger women being diagnosed with rectal cancer who might need more, who will be treated with radiotherapy and therefore be dealing with menopausal symptoms. And again, it's usually permanent and irreversible. And obviously there are other short and long-term effects associated with radiotherapy other than just menopause symptoms. Chemotherapy, as Martha mentioned, the certain types of chemotherapy, depending on the specific drugs that are used, can be toxic to the ovaries and lead to menopause symptoms. But this is the kind of tricky area in that sometimes it can be reversible and the ovaries will recover their function after the chemotherapy is stopped, and for others it will be permanent, and we don't really have a good way of figuring that out in advance of giving the chemotherapy. And for some women, you know, their periods might return, but they still might have persistent symptoms, and it can be a tricky, it's kind of a grey area for patients often, is they don't know where they fall in this menopause range, and the conversation is, am I menopausal, am I perimenopausal, and trying to figure all that out can be quite difficult. But we know that if chemotherapy is given closer to the natural age of menopause, then it's more likely that menopause will be permanent after chemotherapy, but it's not accurately predictable. Endocrine therapy, again, as Martha mentioned, so Zoladex injections, tamoxifen, and aromatase inhibitors such as letrozole or exemestane. There's many different brands. As many of you will know, are given commonly after breast cancer to reduce the risk of recurrence, and these can induce menopause symptoms. And tamoxifen and aromatase inhibitors work by lowering estrogen, which can induce menopause symptoms even in women who have already been through menopause, which can be obviously difficult to cope with, but also kind of a surprising side effect when they may have already been through menopause many years prior. So the main, we see long lists of menopause symptoms, and often there's significant overlap between what are considered menopausal symptoms and sometimes the symptoms of normal aging. And specifically in the cancer setting, there's an often overlap between the common toxicities of cancer treatment and menopause symptoms as well. And then obviously, as we spoke about, loss of fertility, and how that can also make dealing with menopause symptoms more challenging. So symptoms that we definitely know are due to menopause, as Martha mentioned, no or irregular periods, the hot flushes, sweats and so on, and the genitourinary symptoms, the dryness, mood symptoms, and sleep disturbance are accurately attributable to the low levels of hormone associated with menopause. And it's best to consider them all as sort of an interplay of each other. So we've got hot flushes, night sweats, hormone changes, which are inducing sleep problems. Poor sleep leads to stress, anxiety, low mood, and so on. And then you see a lot of other symptoms which are commonly reported as due to menopause, but are really quite poorly understood. So brain fog or cognitive problems, and significant overlap between cancer treatment causing those symptoms and menopause being implicated as well. And it's poorly understood, you know, why that is, but a lot of patients will have that experience. Aches and pains, again, very common with the aromatase inhibitors. Dry eyes, skin and hair is very common in normal aging, and weight gain and change in how our distribution of fat across our bodies is a normal part of aging as well, but also often implicated in menopause. So how is menopause diagnosed then? And often with difficulty. But if you've gone into menopause because of surgical removal of the ovaries or pelvic radiotherapy, no testing is needed in that particular instance, as menopause is inevitable. But blood tests can be helpful if you're under the age of 45, but again, levels can fluctuate, so the blood test can sort of trick you almost. And so if you have symptoms and have had, that's probably the best measure of menopause and menopause symptoms often. So treatment, for many women, obviously everyone's experience of menopause is completely unique. And you often, some of the patients who I would have met through my research would often have described, oh, my friend had this experience, but I've never had that, or my friend was better than me, what did I do to get, you know, such strong symptoms? And I think, you know, every woman's experience of menopause is so unique that, you know, comparing yourself to others is not really helpful. For many women, they have no symptoms at all with menopause. Many have mild symptoms, and some have severe symptoms. So I think, you know, if you need treatment, you need treatment, and it's important to ask for help. So menopausal symptoms which aren't impacting your quality of life and happening at the normal age that you're able to cope with do not necessarily require treatment. And sometimes it's through my research, patients were very worried about their cardiovascular health. But having menopause symptoms at the normal age doesn't mean that your risk of menopause is any higher than any other woman of this risk of cardiovascular disease isn't any higher than any woman of the same age, or if you're going through natural menopause. And treatments, as Martha's mentioned, can be hormonal, non-hormonal, or non-pharmacological. And a lot of patients, the main reason people didn't want to participate in my research was because they didn't want to take medication, because they were already on tamoxifen or other medications like that and didn't want to take something that was going to help with the symptom of something they were already taking. And that's absolutely fair enough. So looking at those non-pharmacological options are really helpful. Simple strategies which sometimes can sound a bit patronizing, but in terms of coping with the symptoms, avoiding triggers, wearing breathable fabrics and layers that you can put on and take off. And I'm sure if anyone here is used to the fan by the bedside and a cool drink nearby. Cognitive behavioural therapy, there is a website, menocare.ie, and there's a psychologist who is on that, who's accredited by the British Menopause Society to provide cognitive behavioural therapy for menopausal symptoms. So she runs groups and individual classes, and there is a worksheet or a fact sheet freely available online that's tailored to patients that can be easily searched for and gone through. You can work through that yourself, sort of, and there are workbooks and things online as well if cost or access is a problem. And looking at HRT, it is the most effective treatment, but it does not eliminate all symptoms, and it's most helpful for the hot flushes and sweats. We also see benefits for sleep, mood, and bone health, but it does not seem to help with brain fog or aches or pains from the available information that we have. It can be given as patches or gels we put on the skin, or tablets, and estrogen only is given in women who have had hysterectomy previously, and estrogen and progesterone together if your uterus is still in place. And if menopause is happening early, so under the age of 45 or in the premature setting, and there's no reason not to take HRT, then it should be continued until the natural age of menopause, and then any decision to continue beyond that is made on an individualized basis. So this is just a kind of a repeat of Martha's slide earlier, which showed the different types where you can consider HRT safely if needed, and the other groups where it may be less recommended, and then certainly in breast cancer we would not recommend it. And the reason for that is these three large studies, and you do hear sort of conflicting information about whether HRT is safe after breast cancer a lot of the time, and there are observational studies, so studies where we look at people sort of as a snapshot in time, and did they take HRT and was their risk of breast cancer increased, and those studies give us different results. But these three studies are really well designed, carefully orchestrated studies where they compare the HRT to placebo over time, and it shows that someone with a hormone sensitive breast cancer who does take HRT, their risk of recurrence is increased. So these studies provide the most reliable evidence there is for the use of HRT after breast cancer. So while the observational data tells us one thing, these more robust, larger, well-designed studies give us much more reliable scientific information. Martha already spoke about the local symptoms and the impact of those, and Yvonne here beside me has this really good leaflet about vulvovaginal health, which is a really excellent resource and freely available on the This Is Go website for anyone who wants to read more. It's really detailed, goes through the hormonal and non-hormonal options for managing these symptoms. And then just to briefly touch again on these non-hormonal medications. So again, when I was sometimes doing the research, as I said, most people didn't want to participate because they didn't want to take a medication, and sometimes people balk at the idea of taking an antidepressant. And I always was very clear that we're not recommending the medication because we think you're depressed, or we think that these symptoms are in your head or anything like that. It's that these medications, for whatever reason, we don't really understand why very well, do help with hot flushes and sweats, and also mood. So these medications do work. Oftentimes you might need to take more than one of them, and oftentimes the dose needs to be increased if it's tolerated. But they're unlikely to eliminate all symptoms. And they're probably not as effective as HRT for hot flushes, but they are an option if HRT is not an option for you. Bone health and cardiovascular health are often very important patient considerations. And if HRT obviously is helpful if you can take it, but if not, calcium and vitamin D supplementation, avoiding smoking and taking regular weight-bearing exercise is really good for your bones, but also good for your overall health, particularly your cardiovascular health. And sometimes people can feel like HRT is something they need to take to prevent heart disease, but it's not recommended as to prevent any cardiovascular disease for anyone. Martha already mentioned these emerging treatments, which are very exciting, and we are hoping that they'll be available on a trial basis to Irish patients, hopefully soon. And then in terms of where you can go for help, the thisisgo.ie website is really useful. Even if you don't have a history of a gynecological cancer, there's lots of information which is applicable to all anyone who's experienced of any type of cancer, really. The Women's Health Concern website is the patient arm of the British Menopause Society, which has really good, reliable fact sheets. The Menopause Matters website and the mymenoplan.org website is really excellent. Goes through a lot of menopause symptoms in great detail and the different treatments which are available in the research to support them. Your GP is a really good place to start. Most of the menopause experts in Ireland are GPs. And then the complex menopause services, there's one open in the National Maternity Hospital at the moment, but we know that there are others due to open in this part of the country and as well in Cork soon. So that's going to be, I think in the service in Dublin, more than 50% of referrals are from people with a history of cancer. And so this is a huge, these complex menopause services are really going to be beneficial for people dealing with cancer-associated menopause. And in terms of getting help or how you can ask for help, your oncology team, oftentimes you can feel like the focus is on the cancer and are you taking the tamoxifen and everything else, but particularly your clinical nurse specialists are really important advocates for patients, and often it can be a good place to start because they can advocate for you on your behalf, I suppose, with the medical team. And I am a doctor, so I can say that sometimes we can be a little bit black or white and things get better or they don't. And sometimes we can be a little bit more not great at having those sort of grey conversations where we have reach an agreement that things might get better. They may not be perfect, but they may be better than they were before. And we can sometimes not be great at teasing that out in a consultation. Talking to friends, family, colleagues, coming to events like this can really destigmatize the experience of menopause. Every woman on earth will go through menopause, so why don't we talk about it? I think if men had menopause, it would be top of the agenda. And obviously your local cancer support centre, I'm sure you're all linked very closely here, and the Irish Cancer Society are a great help as well. So thanks very much.
Good evening, everybody. My name is Yvonne O'Meara. Firstly, I'd like to thank Jacqueline, and I always find it a mouthful, East, Galway and Midlands Cancer Support, for facilitating this. It really is wonderful, and I'm so impressed that most of you have had to endure difficult driving circumstances to come here this evening. So thank you from Martha, Fionán and I. We are very grateful. So I'm actually going to talk about, I think Martha was kind of alluding that I might be talking about psychosexual stuff, but I'm not this evening. I'm talking about how you can help research in different forums in a way that you can, I suppose, help us understand what it is that you go through in novel ways that maybe you're not aware that you can. And so one of the, I'm going to talk about two particular projects this evening. My background is I'm a psychosocial oncologist and a systemic psychotherapist, and I currently am employed by the Irish Cancer Society vicariously through UCD as the Women's Cancer Survivorship Research Coordinator. I have to say I recognise some of the people in the audience, and this is through a variety of channels, and it's lovely to see you here this evening. So the Women's Health Initiative encompasses 3 sites in Dublin. It's an Irish Cancer Society funded initiative, and what happened a number of years ago was Dr. Sharon O'Toole, who's in the audience there, Professor Donald Brennan and myself met with the Irish Cancer Society to highlight the deficits that existed for women in Ireland experiencing particularly gynecological cancers. They listened, they put a call out, and a number of sites were successful. Cork and ourselves and Galway have now come on board. It was initially a 2-year programme, and it's been extended for a further 2 years, and we're just about to start our 3rd year. So I have a job for another year and 10 months, which is great. So it encompasses the Mater and Vincent's and the National Maternity Hospital in Dublin. The team comprises of 2 nurse specialists, Aideen and Louise, and it also comprises of a SPR, Fionán, used to be in the middle there, but now he is sadly departed. And so the new fellow who's going to be for the next 2 years is Teresa Tracy and Professor Donald Brennan there to the left. So tonight I'm going to talk to you about the PPI, that's Public and Patient Involvement, the Diagnosis Delivery Project, and the This Is Go project. There is another number of projects that we've also rolled out, but I won't be talking about those this evening. Fionán spoke about one of them, Teresa Tracy's Sleep After Cancer Study, and we also have a gynae-oncology nurse-led support clinic in both of the cancer sites. So the ISGO, the Irish Society of Gynecological Oncology, and you'll find we're all about go in this space, gynae-oncology. Public and Patient Involvement was founded in 2016 by Dr. Sharon O'Toole and myself. And really we wanted to create a platform for patients whereby there was a partnership between us and like healthcare professionals and the patient. We really wanted you to feel heard and what it is that you were telling us, how could we channel that into research? And so we dabbled with the idea of patient-led research, of which we successfully did. We looked at communication in an outpatient setting. But it meant when I took up this position, I had a group of individuals who had been impacted by a gynecological cancer or were BRCA or a breast cancer that were interested in promoting change through research. And there's been a lot of programs over the last number of years where I've had to put call-outs and I've been able to populate them. And so I have cards, and if any of you are interested in joining the ISGO PPI, it's free, obviously, and you're paid for your time as you contribute to the research. We would love to have your lens. It's really important. So the Johari window is a therapeutic tool that I use quite a bit in my clinical practice. However, the more I work with PPI, the more I find that it is most helpful in this setting. So I was presenting this morning and my audience was predominantly physicians. So now I have to switch it because my audience is predominantly patients. So there are things, if I look at, say, the blind spot, there are things that you know about the hospital system that I don't know, because I haven't been a patient that's experienced a gynecological cancer or a breast cancer. I don't know what it's like to navigate that system. But as a facilitator of PPI groups, I know that you know this stuff that I don't know. And I can extract that from you, and I can channel that into meaningful research. And so there's another piece, though. There's things that you don't know that I know. And so, for example, when I'm facilitating a workshop, you may bring it up that a physician never brings up sexual wellness to me in an outpatient setting. And I might say, okay, I know why they don't. Maybe some of them themselves have a lousy relationship. Maybe they have a sexual dysfunction themselves. They can't bear to bring it up or can't bear to talk about it. I'm not saying that everybody who doesn't talk about sex has a sexual dysfunction, but what I'm saying is there are a variety of reasons why we don't bring it up in that setting. And so for me, I'm able to say, okay, something's happening on the physician side or the healthcare professional side that the patient's needs aren't being met. So how can we meet their needs? And so I'm able to see both of them. And then there's unknowns to us both, but I won't get into that today. So one of the projects the first project, the diagnosis delivery project, having worked for years and years with patients, I know when you're told your cancer diagnosis, it's highly emotive. And I'm sure as I talk about it, you're all brought back to that time, whether you were given a warning shot, a definitive diagnosis, whether it was a recurrence. They're all pivotal times in your cancer trajectory. And so when it goes well, patients can focus on the things that are important to them, i.e. concentrating on quality of life, going through the treatment and getting better and focusing on wellness. But if it goes poorly, what I often find is patients can get very stuck at this phase, and it can profoundly impact their coping ability, irrespective of their prognosis. And so it's really important that we try and support the physicians. I don't envy it. There's no one size fits all in telling you news. But often it can be very, very tricky because you come into that space with an invisible backpack that the physician doesn't know what's inside it. And they too have an invisible backpack. We don't know what's inside that. And you hope that you get it right. But it's a highly, highly tricky time. And so we were thinking, how might we improve that for patients? How might we make them more informed? Because if I was to ask you, do you remember everything that was said in that initial consultation? I'm pretty sure you wouldn't. So I was thinking, let's have a card. And so have your name, your medical record number, your provisional diagnosis, your confirmed diagnosis, your stage, grade and histology. I know that patients get confused with what all those mean. I do. And so let's write it down so you go home and you're able to, and if you do search the internet, well, you'll have the facts, what it is that you have. I thought that maybe you would want something like the Irish Cancer Society numbers on the background, or the local health centre and the local cancer support centre, but actually know what the patients, the workshop that I ran, what they wanted was, who was the surgeon that I saw today, who was the nurse, and how can I contact them? But it was through a discussion with the lady, Kim Hanley, in one of the workshops for the Diagnosis Delivery Project. She spoke about her consultant drawing an image of her cervix. And she said she still uses that as a reference point today to prompt exactly where the cancer was and the understanding of the surgery that she had undergone. And I thought, this is genius, an image of a cancer that she was able to go home. And what we do know, and probably some of you experienced, is some of your physicians will draw, but it remains on the chart and you don't get it to take home. So we came up with the diagnosis delivery image. And so, Fionán, would you mind that book there? Give one to each of the room because it'll be easier to understand. Sorry. I'm like, I don't know, did Gay Byrne have a helper? I know, I'm like, roll it there, Colette. But yeah, so basically now if you go to any of the gynecological cancer centres in Dublin, and rest assured, I'm on the road in January, it's going to be at a cancer centre near you if you have gynecological oncology cancers. So that didn't make sense if you've gynecological cancer, sorry. But it goes through your procedure and the likely complications. Now it is not it's not a consent form, but it certainly improves consent. And so after there's the cervical one, and radiotherapy side effects would be included in that because we know most of you who've undergone cervical cancer have radiotherapy. So next year, as I say, I'm going to be rolling it out across Ireland. But what's really exciting about this is I presented it to ESGO, which is the European Society of Gynecological Oncology, at last year's meeting. They approached me in January of this year and asked me to present to it again in Berlin, and it's been successfully nominated as the Engage 2023 Project of the Year. Now, what does that mean? It means right across Europe, any hospital that is going to be ESGO accredited, of which there are ESGO accredited sites in Ireland, the Mater being one of them, and Vincent's, this, which has come from a patient, will be across all of the centres. And what have the patients said of it? It is enhanced memory recall at a time where it's incredibly distressful or stressing to remember, that it acts as a memory aid, that people are able to go home and go, this is, oh yeah, this is where it is, and this was rolled out at a time where hospitals were pretty much closed because of COVID. People were only allowed one person in, and so my evaluation again was during the height of COVID. So unequivocally successful and supported. I also asked the gynae oncologists what's their experience of it, and again, overwhelmingly positive. It adds focus and structure to the consultation, and they feel that they have a more informed and engaged and activated patient. So this leads me nicely on to the second project that I'm going to talk about, is the thisisgo.ie, This is Gynae Oncology. Could I have a show of hands, all of the people who have heard of the website prior to tonight? Okay, so very few people. Okay. So that's great, because now there'll be a hell of a lot more. So This Is Go is an online platform. It's a one-stop shop for those impacted by gynecological cancer. So you log in, you put in your name, you put in the type of disease that you have, and you put in the stage that you're at. So whether you're newly diagnosed, whether you're in surveillance, whether you have a recurrence, whether you're a partner, whether you're a healthcare professional, there's a pathway for all of you. And it'll churn out exactly the treatment that you've had or that you're about to embark on. And then any other aspect of cancer that often isn't spoken about is there. So how to communicate to children, sexual wellness, lymphedema, menopause, whatever the side effects to your particular cancer is available to you. I cannot stress enough how much energy and time from excellent clinicians around the country and overseas has gone into populating this platform. There's over 400 articles in it, and it's, I hope, meets most people's needs. So you have videos versus podcasts, and obviously the written word. So that's what that is. But public and patient involvement have been heavily involved in it from the get-go. So while I'm running while we're doing a clinical pathway, so meeting physicians and oncologists and going through exactly what is required for a person who has stage 3B ovarian cancer, I'm also running a workshop with patients, getting what they feel should be populated and go into the website. So that's an example of one of the early stage is am I doing time? That's one of the examples for the early stage platform where this was for ovarian cancer, and just literally mapping it out. Then our developers, Full Circuit, they draw up this grid, which then is invested into the website. So for the first phase, we did cervical cancer, and it took us a year from infancy to launching it. And it was launched in September 2021. We consulted over 70 people. There was about 60 plus hours on Zoom and phone calls. Full Circuit, our developers, there was 43 hours of Zoom with them and 2 2-hour workshop. And with regards to the team of which Fionán was involved in at that time, how long is a piece of string? This is what you'll get with regards content. So as I say, it goes from the most clinical to things that have been so helpful. So there's videos of gynae oncologists explaining why they ask the questions they ask, what to expect at the second consultation, what to expect when you're leaving hospital, tips from patients as to how to protect that womb. So it's really, as I say, practical. I don't think there's any aspect of it that doesn't meet somebody's needs. We also have a section called Decoding the Science. So if you're into scientific paper, we have broken down those papers into layman's terms, which gives you an insight into why the gynaecologists and oncologists make the decisions that they make around your treatment. We also have a symptom tracker and a service directory. So this is the very first pathway. The purple is the PPI involvement. So there was over 13 engagements with PPI before we launched it. Then this is the ovarian cancer one. As you can see, we've become a lot more streamlined. So 3 interventions. So now I'm able to say, and I just ran the vulva and vaginal platform, our workshops a number of weeks ago, where I'm able to say, before they come online, can you please log on to This Is Go and look and see what we're talking about? So they have a template that they can look at. And how would this work for vulva and vaginal cancer? What are the things that you would like on it? I then meet them. I facilitate a workshop, I interpret the workshop, we get the themes from it, and then we populate it. And they get the option to review the website before it goes live. And so to date, it's multinodal, so we're continually getting feedback from the type of things that are in it, what articles are being accessed the most, so we can push those articles to the patients who are logging on. So to date, this is what you'll find. We've cervical, ovarian, we've the BRCA and Lynch pathway done, and we also have uterine or endometrial cancer, and by the end of the year we will have vulva and vaginal. So that's just the timeline. So to date, there's been over 742 profiles created. So that's a 21% conversion rate. So I wouldn't have known anything about conversion rates until I started working in this platform, but I do know a lot about online shopping. And I'm told that I will visit a website many times before I purchase, and that the conversion rate for any of us when we're online to do something with a website, so whether it's signing up or shopping, is 7%. So the fact that we have a 21% conversion rate is really high, and we have no budget to promote it. So what are the breakdowns? So there's over 325 people who have made a profile within cervical cancer. Healthcare professionals is 70, but actually we think it's close to 200, because initially we didn't have a healthcare professional pathway. And you might ask, what goes into that healthcare professional pathway? Well, how to communicate and how to ask their patients how to take a sexual history. So we're meeting and doing this kind of dual process on both. So we're trying to meet the healthcare needs as well as the patient's needs. And then we're also, I suppose, uterine cancer is the one that's been launched at the latest, and there's 63 profiles in that. The physicians will use it in the centres as a, I suppose, and Fionán, you can talk to this too, that when they meet new patients now, they're encouraged to open a profile at that time, so they go home with the diagnosis image, and also they have a profile created on This Is Go. So basically, if you feel overwhelmed, everything I'm telling you today is on this platform, so don't feel that you can't, that you have to remember there is a resource here to support you. What are the most popular articles? I'm not going to go through them all, but as you can see, diet and exercise, menopause is up there, financial matters, decoding the science, psychological wellness, sexual wellness, and BRCA. To date, 32 counties have participated, which is great, and over 44 countries outside of Ireland have visited it. There are limitations to public and patient involvement. Often people may have their agenda, and they may have a gripe with a particular area of their experience, and so it's up to me to manage that it doesn't become that. How can we use your negative experience and turn it into something positive? So I'm very structured and focused when I do run these workshops. We also know that you have a restricted lens. You only see your disease and not others, and so if you haven't had radiotherapy, it's unlikely you're going to read the radiotherapy. So it's important when you do run these groups that you have a variety of patients who are at various different stages of the disease trajectory. Obviously the team have to sign off on what goes. So I would have ran workshops where patients would have had very enthusiastic experiences, maybe with green juice diets, and that I can't put that in because there's no scientific evidence towards it. So it has to be something we have to stand over, and we haven't formally assessed it yet, but it is something that we plan to do. These are our collaborators, of which we're very grateful for, and I'm going to leave the patient have the last word. So Seamus tells me that the video is here. Is that right, Seamus? Oh, maybe it is. Hold on. Maybe it is. Yeah. So this is a promotional video that the Irish Cancer Society shot for me. So it's been shown once already today at the gathering, and you're the second audience to see it. So hopefully it'll work.
The Irish Cancer Society's Women's Health Initiative is about improving the health and well-being of women who have been impacted by a cancer diagnosis right across the disease trajectory. PPI is public and patient involvement, and sometimes it can be referred to as public and patient engagement. Often research can remain very abstract for patients, and for this, the Women's Health Initiative, we really wanted patient involvement to be absolutely embedded in it. One of the projects is the thisisgo.ie online website, where at each disease stage that we have rolled out, PPI have been absolutely fundamental to the rolling out of it, the embedding of what we go into it, but actually also to its success.
When you're in the clinic, you're really discussing scan results, you're discussing, the immediate cancer treatments, I suppose, but you're not really discussing that much about quality of life. I became a patient advocate And that's when I was able to actually identify the issues that women that weren't really being addressed, I suppose, in the clinic, and I was able to give my opinion as to, you know, where I think the supports are needed in order for people to live with cancer and to live with good quality of life. It gave me kind of a voice, and it also gave me an interest in you know, wanting to make change and improving the services, really.
The resources that are being developed under the initiative are so helpful, and I really loved it from the get-go. The fact that we were building something that could only have dreamt of when I was diagnosed, this whole support network that now women who are diagnosed would have somewhere to go to get support, to get resources, to see the diagnosis delivery card being presented European-wide is just amazing. That started as such a small little input I had at the start, and to see how it has grown just shows what can be capable of and what we can do to further improve gynae services in Ireland.
If you are considering trying to shape the future of cancer in Ireland and you are a cancer survivor, please engage in a public and patient involvement platform. We need your voice.
Actually, I think it's patient and public involvement, so I'm like wrong forever. But anyway, it's a PPI. Anyway, thanks very much.